I've actually seen quite a few cases have been posted online, or one or two articles written. People have said, it's not sure if it's going to work. Actually, it's not going to work. And the way I view it is, if someone's got an instanding premolar and they needed Dahl because of that, why not just have a couple of months of ortho? It's not a rocket science to move that too. That's the point. If you've got a little bit of, Dahl is effectively like doing some ortho. It's like doing some ortho, but it's like a fat anterior bite plane.
Welcome to the Protrusive Dental Podcast, the forward-thinking podcast for dental professionals. Join us as we discuss hot topics in dentistry, clinical tips, continuing education, and adding value to your life and career. With your host, Jazz Gulati.
Hello everyone and welcome to episode 17, the one that so many of you have been pestering me about. I sort of teased you with the first episode with Dr. Tif Qureshi, Dahl Part 1, and then I threw in the 12 Rules of Dentistry, which was, pleased to say, greatly received. And then a lot of people got value from that, and now to continue on from that cliffhanger I left you on with Dr. Tif Qureshi, I've got Dahl Part 2 for you today. So this will be the spicy part. Now, before we get into an excellent conversation with the top man that is Dr. Tif Qureshi, some important things. Firstly, a very happy new year to all my listeners. Thank you so much for tuning in my first proper year. 2019 was really the first year I started podcasting, and honestly, I really, really appreciate you taking your time to listen to it. I struggle to listen to myself, I make myself cringe, but the fact that other people are listening to me is just, it blows my mind. So thank you so much. A massive shout out to one of my listeners. I'm not going to embarrass him, but he messaged me to say thank you because somehow the episode with Drew Shah and myself, episode 3, Transition to Private, had such an influence on him that he decided to change his environment, change his mindset, and he thinks that good things have happened because of it. So now his goal was to be in full-time private practice, and now looks like in the coming months he'll be able to achieve that. So if I've had that sort of influence on him, that has literally made it completely worth my while, and that's exactly what I'd like to do for as many people as I can. I love sharing my enthusiasm and my love for dentistry, and it's so great to hear stories like that. So thanks so much for reaching out to me, and thank you Drew Shah as well for a great episode that we did in episode 3. Secondly, I'm really sorry that I didn't give you a protrusive dental pearl with the last episode. To make up for it, I'm going to give you today a really, really awesome protrusive dental pearl, which is going to save you hundreds of pounds potentially. Okay, so hear me out. This pearl or this hack will save you money on buying a composite heater. So the first question that some people ask when we talk about heated composite or a composite heater is, why would you heat the composite in the first place? So from my understanding from in vitro studies, it suggested that there are improved physical properties, a higher percentage cure, micro-mechanical details of that sort. Apparently heated composite is a good thing to use. However, I like it because of the physical changes that happens. When you heat composite, it becomes much less viscous. The wettability of the composite significantly improves. So people use it for bonding Emax onlays, for example, posteriorly. I use it also for injection molding a la David Clark, i.e. the BioClear technique, which I love. I'm a huge fan of BioClear. So to use heated composite ensures that it will flow into all the nooks and crannies of the BioClear matrix and prevent any air gaps and air voids. So it's a great thing to use. So that's why you would essentially use heated composite. So what is a less expensive way to heat composite? These composite heaters can cost a significant amount. I've tried the following methods before over the last 6 years. I've tried a cheap £3 Chinese make coffee mug heater, like a USB one. And that worked well, it actually did work. And it broke a few times. You just buy a new one. It's really cheap, buy cheap, buy twice and all that sort of stuff. So it would work well. But the only issue is that I had no control over what temperature I was achieving. And apparently the literature suggests, and when I mean the literature, I mean Jason Smithson wrote it on Facebook, so it's gospel. It should be about 55 degrees. So I didn't know if I was hitting that 55 degrees or not. Another thing I've tried is by putting the compule up by the operating light. So your operating light, a lot of these lights have like a little gap. Like you can almost get your finger inside this little gap. It's difficult to explain. So you can put your compule inside this little gap, and our light gets really hot. So the composite compules can get really hot through that method. And that worked really well. The problem with that is what happened to one of my patients once is I was moving the light around and the composite compule, sort of fell on his head, which was funny at the time, I guess, but the patient was cool about it. So that can happen. Also, again, there's no control over what temperature I'm actually hitting by using the compule up in the light. the hack I have for you, the pearl I have for you, is to buy a really posh coffee mug heater. So it's a really posh one. It's by a company called Kosori. It's available on Amazon. I'll put a link to it on my Facebook page and my blog, www.jazz.dental, under the sort of episode 17, so you can click through. And it is phenomenal. If Tesla made coffee mug heaters, that's what it would look like. It just looks really swish. It connects to your mains, and you can actually control the temperature. So I'm going 55, 60 degrees, and I can be confident that we're hitting that. So it looks really nice in front of patients. It looks professional, and it doesn't actually look like a coffee mug heater at all. You can make it what you want it to be. So using that, which is just £30, is fantastic. So that's my major protrusive dental pearl to make up for lack of a pearl last time. I think if you haven't got a composite heater and you like to use heated composite, get it. It's just fantastic. The gold standard, obviously, is to buy a proprietary composite heater. But these can cost upwards of £400 to £1,200. And I'm not against buying it. I just, so if you please buy the best you can afford. But here are a few reasons why I am not in a position to buy a £600 composite heater. Number one, I'm an associate. That's pretty self-explanatory. I'm taking my gear to different practices, so I don't want to be moving around such expensive gear all the time. And number two, the money that I don't spend on equipment, I get to spend on courses, and you all know how much I love going on different courses. So, for me, I value courses way more than paying, I apologize for saying it, but over the odds for some materials. So I mentioned about this composite heater on a Facebook group, and Steve walked in from Optident. Big shout out to Steve, awesome guy, awesome company, which is Optident. He actually made a counter argument and said, hey, look, if you're undercutting the UK dental suppliers and you're going to Amazon to buy this tool to heat composite instead of buying a proper composite heater, then I might as well go to Turkey and get my implants done. Well, I respectfully disagreed with him. It's very different to that. What I'm not recommending here is to go on eBay and buy counterfeit handpieces. I'm not saying that. What I'm saying is where you can save money on things that, you don't actually have to put in a patient's mouth, do it. Why should we pay over the odds for something that we can achieve in simpler and cheaper means? I know plenty of people that use a baby bottle warmer to heat their local anaesthetic or hypochlorite. So same principle really. So I'm totally cool with that. If you think it's immoral, then go ahead, buy the expensive composite heater. If you can afford it, do it. Totally. That's the best thing to do. Hope that pearl was useful to you. And now we can jump in and join Dr. Tif Qureshi, what you've been all waiting for.
And this is, one of the questions that we were sort of thinking about here was, why do people not appreciate it? And one of the biggest problems is I think a lot of people use Dahl on the wrong patients when it's too late. And Dahl is really for patients that you've had a relationship with. They understand what's going on. And to actually say imagine to a brand new patient who's got a bit of wear on the lower anterior teeth, imagine trying to say to them, right, I need to build your anterior teeth up to improve your anterior guidance and disclude your posterior teeth, blah, blah, blah. They go, what the hell is this guy talking about?
I've been there, Tif. I've done that. So you must teach me and my listeners. Hopefully I'm better at it now than I was. But to tell me about how you would approach that, and then how to actually communicate to patients, you've lost your canine guidance. Interceptively, you'd benefit from a interceptive Dahl technique. So how do you approach that?
It's all part of for me, a much more everyday comprehensive checkup. And I don't mean a comprehensive checkup as in like a comprehensive exam. I mean, you have your comprehensive exam, which, you deal with a new patient. But actually, for every checkup, there's lots of little things that we can also be looking for, talking to the patients about, explaining to them, that then helps them understand the dynamic picture of what's going on. So, we've already mentioned tooth surface loss, looking very carefully at dentine and making sure they understand that, this stuff is 6 to 8 times softer than that stuff. A lot of people don't understand that. When I actually give a lecture and I ask dentists and I talk about dentine enamel and I say, what do you tell patients about how soft that is compared to, literally one hand will go up in the room. So it's not something dentists potentially confident in saying, but actually patients need to know that stuff is a lot softer, and as a result it will wear, erode and whatever quicker. That's one thing.
I tell my patients, but only because I went on your course in Sydney. So I do tell my patients, I show them, because I take my DSLR photos in a comprehensive new patient examination, and I show them, it's like, yeah, that, you know what that is? And they say, no. They say, well, that's a dentine. That is 7 times softer, is what I say. I just leave them with that. So it's co-diagnosis.
Exactly. But then the key thing is, if you do that on a checkup, you then reshoot that image 6 months, a year down the line. What I'll say to the patient is, okay, there is some wear there. I said, that's not how it should be, but don't panic. I said, your tooth isn't going to fall out from being like this. But what we want to do is to see how it looks in a few months' time, see if your bites change, see if any of the anterior contacts, and critically also, of course, see if your teeth are moved. Because if you have the combination of anterior crowding and wear, then you have this whole kind of concept of potentially constricting envelopes, not in every patient, but in some patients. And I found that a really easy concept for people to understand. And, if they see a lower tooth sticking forward and then an upper one subsequently sticking forward as well, and one upper one sticking back and a lower one sticking back, doing a very simple, and this is a thing that I do in every checkup, I do a very simple Fremitus check on every single checkup, every time, to make patients aware of their tooth position. And the very simple way of doing it is I literally put my fingers on their teeth, I lean on their teeth, front 4 fingers on the front 8 teeth, and I'm literally squeezing the ligament. And I just say, it's going to look like I'm playing piano on your teeth. I said, now I want you to bite fully on your back teeth. And actually what often happens is a tooth that's out of position, the one tooth or two teeth that are out of position, they start to knock more heavily against one of the lower teeth. And I say to the patient, can you feel that? And they'll say, yeah. I said, well, that's probably happening. Not 100%, but probably happening because that lower one's drifting forward a little bit. And the key point is it's continuing to slowly drift, but it's slow. So we'll look at it again in 6 months or a year. We'll take a photo. Now we've got a scanner, so I'm telling him we'll scan it. And they said, what we'll do is we'll look and see whether it's actually changing. And you know what usually happens? 1 year, 2 years, it's happened 5 years later. A patient's come in and said, that you're telling me that those teeth are wearing a little bit. I think that tooth is moving, and I'm sure that tooth's darkening a little bit as well. Then we say, okay, this is what we can do, as we've discussed, and we go from there. And that, and in a nutshell, a lot of those cases described in that way, and not even with tooth position, but just with tooth surface loss, patients come back a little bit later, becoming a bit more aware of the colour, the shape, the edges, the sharpness, and then they say, let's get it fixed. So
hats off to you, Tif, because no one actually talks about that. No one ever talks about, 5 years later, I'm then going to give them the treatment plan. No one talks about that. So ultimate respect for you for having such a long-term view with that. And also, that's a great clinical tip, to use your 2 hands, your 4 fingers, front teeth, push down, ligament squeeze, bite together, and that really makes it tangible for the patient.
The key thing is not, you mustn't panic people. It's about, I just say, I always reassure them that this is normal. This happens with a lot of people, tooth movement and wear, it's a normal thing. Some people might call it aging, but actually it's preventable. So the key thing is, the problem is, like I said, we got back to what we said earlier, there's this whole kind of selling pressure people have, and there's all these gurus that teach you how to sell. And somehow if you don't make the sale on the day, you're upset. The way I describe it is what you should actually do is tell, don't sell. If you tell people what's going on, which a lot of dentists don't tell, they talk about caries, they talk about perio, but they don't look at occlusion, they don't look at slow occlusal changes, they don't look at slow tooth positional changes. If you tell people about that, patients are not as stupid as we think. Okay, patients do understand. I talk about envelope of function every day in my practice in Kent, and every single day, one patient walks back in through the door and asks me how their envelope of function is, and I'm not joking. And that comes from literally a 2-minute demonstration of how their teeth should be moving, and then how their teeth are actually likely moving, and how much overjet they've got and how much overbite they've got. And that is a normal patient.
I feel sorry for these patients who, when they geographically relocate and they find a new dentist and they ask their dentist, how's my envelope function? And how startled the dentist must be. The thing is, envelope function is quite an interesting one, actually, because it's theorized. There's Pete Dawson's work and Frank Spear's work on it. There's not, unfortunately, there needs to be real good clinical data on it, because what I found quite amazing is that in some areas of the profession, some people have not even heard of it. Like in orthodontics, there are some orthodontists who've never even heard of it. Never heard. It's true. I've just finished my ortho diploma, and that was not mentioned. This is quite a comprehensive diploma, and it was not mentioned once about the envelope function at all. And I think it's a key concept. But we have to be honest, Tif, and you know this more than anyone, that there are some camps who believe that actually there is no impact, and they believe it's purely parafunction. Whereas other camps, believe that yes, there is, an element of that constriction, the teeth knocking together more. So, technically, we'll never know. We can never make the study, but it just makes sense in terms of clinical observations we all make. We can see this.
That's exactly right. And you know what? The way I would say is, those in doubt, please show me your case follow-ups 10, 15, 20 years later. Please show me them. You know what? They haven't got them. There's a lot of people that love to talk the talk, but they never see their patients again. And this is the thing. If you don't see your patients again, but you think you're, a real hot shot, you've got no position to stand. That's the problem. And it goes back to, as I said, what's the core problem in our profession? I think actually our professional curriculum has been created for our own convenience, not for the patients. So you advance through your career and you get all these labels, but you're not necessarily actually doing anything better for the patient. What would be best for the patient is that you looked after that person if you carry out a complex treatment. And even if you can't, you make sure the work they had carried out gets looked after. And, tell me anywhere in our profession where that occurs. I think the only area it does, I believe, is perio. I think perio has just got that long-term mentality to it. But anyway, that's quite controversial.
And the studies in perio, the Axelson paper, 30 years and stuff, and that, they're really into that. So I agree. That's probably the area of dentistry we have such beautiful long-term follow-ups
for implants as well, but for different reasons, basically. But that's a good thing, And I think a longitudinal view on everything is a good thing because it teaches us that not everything we do works and that stuff changes over time. So, and it's GDP. It's always going to be the person that's going to see that.
True. Next question I want to ask you is, do you routinely deprogram your patients before starting a Dahl case?
I have to say, my Dahl build-ups are my deprogrammer. so there once upon a time I never did. Then once upon a time I started to, and I started learning about splints and deprogrammers. And then actually it sort of dawned upon me, why am I doing this? Well, actually the thing that I'm bonding in their mouth is a deprogrammer. Okay. And so actually now, if it's an appropriate Dahl case, and we'll come on to that, what's an appropriate Dahl case, because there are a few things that aren't appropriate, but if it's an appropriate Dahl case, actually the Dahl build-ups are a deprogrammer. So what I tend to do is I tend to just build them up so that my initial point of contact is just slightly posterior to maximum intercuspal. And you could say, are you guessing? And actually, for years and years, I guessed. And then actually I started to try to take records. And I then started to set my Dahl up to my supposed CR records. And it made no difference whatsoever. So the key thing is you put the build-ups in, but then it's critical you get the patient back 2 weeks, 4 weeks later, because at that point you may well find the patient's now deprogrammed and suddenly there's an interference posteriorly. I have to say.
Fantastic. And I'm glad you've said that. So how many times has that happened to you? Because you've done Dahl more than anyone probably. So how many times has that happened to you?
Well, I'd say it's quite rare because it's probably 1 in 25 cases. Maybe something like that. And the reason why is that if you think about it, you're actually separating the back teeth. And so therefore, yes, of course, the jaw can reseat and then it can find a new position. But because the back teeth are separated, what effectively then happens is a process of, in inverted commas, natural equilibration. So it's quite rare. I have had to. There's been the odd tooth where you find a cusp of lower 7 or upper 6 or something is knocking where it wasn't before. But it's not that common. And
it's happened to me in my probably the fifth Dahl case I've done, and the patient had deprogrammed, and I was like, oh, okay, this is interesting. So I've had to follow it up and treat it. And there's a really good dental update paper I actually put on as well, where these clinicians, I think Leeds Dental Hospital, had a case where they just went ahead, waxed it up, did a Dahl, and then the patient deprogrammed to quite a significant horizontal sort of condylar repositioning, so that now they were extremely class 2 Div 1. They've lost all their anterior guidance.
Yeah.
So it's rare, though. I agree with you. I was going to postulate 2 to 3%. You said 1 in 25. So we don't have any. I don't suppose we have any data on this, but that's coming from you, I totally respect that. So this is why personally my philosophy is I do deprogram. But I'll tell you about okay, how about you tell me if there's anything else you want to tell me, but also tell me that, okay, once your patients have dialed in, how are you managing them with splints or not with splints?
Okay, so I'll come to that in a second. But basically, another thing just to say, and a lot of the papers that are written on these, if you look at the patients that have been treated, a lot of them are train wrecks already. This is the key. A lot of the cases that end up in universities and hospitals, cases that dentists have left far too long. And so a lot of these patients these patients have proper sort of severe occlusal issues. If I showed you, and I'm not saying that those patients shouldn't have been treated, and of course they need to treat it, but if you look at a lot of the cases that I've treated, they're patients that are early phase. You sort of get my point. So and that's the thing. It's quite a difficult thing to kind of explain. And I'm not saying that the point being is that the patient that was treated in Leeds or whoever should never have probably got that far. That's the point. And that patient has ended up there because the dentist, couldn't do anything about it. Dahl is a treatment for almost your everyday patient. It's a treatment that I actually believe virtually every single person, now you put it at a high percentage of people, at some point in their life would benefit from. If it's only used to treat a train wreck, or if it's used to treat a train wreck, it will be unpredictable and it won't always work. It should be for preventing a train wreck. That's kind of the way we think about it. It's preventative treatment. It should not be as severe. I have used it in cases where there is a lot of wear already, but the patient's now just starting posterior wear, but you can see they're a really heavy bruxis and they're quite young and they've gone through their teeth quite quickly.
And that's exactly the patient that had the condylar repositioning quite significant in my case, actually. So that's why now, since then I've started to deprogram. But I take your point that actually maybe when we're using it appropriately, interceptively, the need for that may not be as significant as those sort of train wreck patients who have had severe occlusal issues, severe bruxism, that sort of stuff.
Exactly. And actually, when I teach in my courses, I'm actually starting, I appreciate that a lot of people that come in and listen listening to this are kind of looking at this for the first time. And what I actually tell them is in those patients, if you can identify proper TMD or someone with a massive shift, I actually don't do it on that case. I do use it on that case, but I wouldn't start with a patient that's got restricted opening and huge clicks and all that sort of stuff and massive amount of tooth surface loss. Really, this is for somebody you build the discussion up with over time. They're losing their guidance. You're trying to prevent them, and through a combination of Dahl and potentially ortho, you're trying to prevent canine width collapse, loss of OVD earlier rather than later. That's really the key. Now, yes, I do use it on patients who do have kind of more severe tooth wear and they're more into it. And if they've just not got posterior wear and I'm just about okay to do Dahl, but they're heavy bruxis, then my strategy is this. I will Dahl them exactly the same way. We go through a period where, there's a little bit of worry and risk when we're waiting, because obviously actually one issue is when you're waiting for Dahl to occur, you can't really wear a full mouth splint or anything to protect it because you're trying to wait for that compensation to actually occur.
I'm going to come on to that because I want to speak about splints. And so at the moment when you're dialing them, you're leaving them nude, no splint.
No splint. No, I do sometimes.
Like an anterior only splint maybe?
But that has to be given to a patient that you trust. And what I mean by that is a patient that you trust to follow the instructions. And the instructions are, of course, that as soon as their back teeth start to touch when they are eating and they've removed it, they must remove it quickly. And that's what also means that you follow them up quite quickly. Obviously, the last thing you'd want is to leave it there and then end up with an anterior bite post-treatment, which is possible, of course. It is possible. So sometimes if I'm worried about that, I will protect them. But actually, so what I used to do for years, I'm being perfectly honest, years and years ago, I would Dahl them, okay? And then if I was worried about teeth chipping, well, back in those days, we gave them a rubber bite guard, which we know are, well, some people actually still believe them, but I think they're completely useless. But anyway, again, I used to give a rubber bite guard. Then I started getting into splints and started, learning how to do splints. I use splints, and I can still use splints. So I started using splints. But actually, I have to say, the vast majority of my more severe wear cases treated with Dahl are now Dahl and an Essex retainer. And that's it. And I found that in most patients is enough. I can kind of think of the last 5 years, there's only one patient whose teeth who kept going through the Essex and then ended up giving them a splint. And I think part of the reason being is that actually having the Dahl build-ups bonded in your mouth it's kind of, it will, because no one really understands why people brux. There's loads of reasons for it. We know there's loads, but actually opening the bite, building the anteriors, it's, as I say, the way I describe it, it's like having a deep anterior splint bonded in your gob that you can't remove. And actually, I found patients, I've got loads of examples of patients who I did treatment on who are severe bruxis, and I dulled them. And actually, some of these people didn't come back for 5 years, and they came back, there was no splint, no Essex, and all the composite was still there. And you think, well, you know what I mean? There's lots of examples, not like one or two, lots. So actually, now, of course, their life circumstances might change, the stress levels might reduce, they might be sleeping better at night, they might,
But if you think of the mechanics of that situation, I mean, you've built someone, you've rebuilt their anterior guidance, so even if they are bruxing, the fact that it's anterior contacts, the muscle contractions are less, and that's part of the theory.
Exactly. And this is the point. Even if you're a bit negative about Dahl, you think, well, what are you actually doing? You're just adding something to the teeth. You're not spending a fortune on it. And actually, it's quite simple to do. It doesn't take very long. And we'll talk about that perhaps as well, about how to do it. But because I think some of the techniques that I've seen become so complicated that actually almost puts people off from doing it. But actually, it's not that difficult, not that simple. But what's the worst that can happen? There's no preparation. I haven't prepared the teeth at all. So even if after, 3 years, it all wears back down to nothing, the way you look at it is, you've got 3 years where there's been no further tooth surface loss. And I take a view really that if I can get anything from 5 to 8 years out of it, even if and I tell the patients, the way you think about it is for 5 to 8 years, your teeth are going to be the same. So there'll be no theoretical aging of those particular teeth. And when it comes back.
Oh, I love that. Aging of your teeth. That's a communication gem because patients need to be, hear it in a way that they can understand. So I'm writing that one down. Aging of your teeth. That's really good.
Because tooth aging it's tooth surface loss, it's taken up of colour, it's chipping, it's movement, and and I think another thing people don't appreciate is how, and particularly I think when you see it over the years, you see a patient over the years, you notice a tooth that has dentine exposure. If you look at a patient over the years, just watch how dark that tooth goes. So again, it's another thing. There's no longitudinal kind of view on it. But teeth go dark, and it's because dentine absorbs stain massively. And particularly if someone drinks tea, coffee, smokes, you just know that someone with an open, dentine, what's called a dentine lesion for a minute, with an open exposed dentine, they're going to get a darker tooth, and that all contributes to aging. So yeah, the point being is that
no, I like that very much. And the reason I asked about the splints and basically when you were talking, I wish we were videoing actually, because I was smiling ear to ear, because this is a huge part of I'm massively into splints and I do all type splints, but my go-to splint for someone, and I'm glad you mentioned it, who has no temporomandibular issues at all, healthy, who has no muscle issues, okay, I am totally happy with a passive fitting. And it has to be passive fitting. I get the lab to block out the undercuts, Essex retainers, so that they're really comfortable and easy, because you don't want to give someone a really tight Essex retainer to put them, the compliance will be less. So I'm so glad you mentioned that, and that's a lot. I use that as a protective appliance. So not really a therapeutic or diagnostic. It's a protective go-to appliance for me because it's cheap and cheerful. It works and it can be comfortable when it's made the right way. So I'm so glad you mentioned that. No one talks about that.
Exactly. And this is the thing. And I'm just, this is kind of what I'm using. I've gone through, through a whole spectrum of usage of various devices, and I did go through a whole period of, experimenting Michigan Tanner style splints. And you know what? I've had great results from various things. But what I do find now is that the vast majority of cases, if they can be, and remember, these are those appropriate style cases, and those are most of the cases I'm treating. I don't treat massive train wrecks because I'm trying to prevent them. That's the point. I get a patient comes in who, needs a lot done, and, I deal with it, and I deal with it as I need to deal with it. But most of them end up with build-up, which I know have an effect, and then vast majority with Essex retainers. And the ones that break through those, or keep parafunction, or who knows, begin parafunction later for another potential reason, those I'm more than happy to go on to some other type of splint for them if they need to. But it's quite rare. And the thing is, I think you can only really judge this if you've been seeing people for long enough to know. It's very difficult to make an assumption of how someone's teeth are going to change 5, 10, 15 years later, unless you see them again, or you have the intention to see them again. That's really the key.
Tif, have you heard of a flexi orthotic splint? Have you heard of this FOSS appliance by any chance?
I have actually, but I don't know a massive amount, but I have heard a little bit of it. I've heard the name.
So I use this in my protocol, and I use this in my Dahl protocol. And what I'll go ahead and do is I'll share a full protocol case on Facebook, and I'll tag you in it. Okay. I absolutely love this splint for Dahl cases. Basically, the acrylic that you mix actually bonds to the polyester copolymer of the splint itself. So I actually use it as an anterior-only deprogram appliance first, okay? And then once I've done the build-ups, the patient doesn't need a new splint. I just gouge out the old acrylic and I reline it.
Oh, right. That sounds quite interesting.
Which is amazing, which is so good. And then when the posterior contacts re-establish, I then will convert them to an Essex, or if they're really heavy bruxes, because one thing you could do with the splint is you can color it in black with the Sharpie pen, and then you can see their parafunctional patterns. And when they come back, they're like, oh my gosh, yes, I'm grinding. So I think you really like this splint. I'll show you. I've got quite a few cases with it now with Dahl, so I'll put one on, see what you think. I'd love to hear what you think about that. So I'll stick that on and I'll tag you as part of this sort of episode. So I'll be sure to. I'm going to make a note to do that now.
Sure. Yes, please do. That sounds really interesting, actually. Yeah.
Okay, so I think we'll have to wrap up soon, but there are some. Honestly, this has been brilliant so far. So I just want to say, have you seen any Dahl cases? No, actually, no, I don't want to talk about that. Let's talk instead about. Okay, so in those cases where Dahl may not be successful, we know it's incredibly successful, especially in the cases that you're doing case because you're doing Tif, because your case selection would be quite good. And so in those cases where it might not go to plan, I tend to have that discussion beforehand as part of my consent process. I might say, okay, in a very small number of cases, it may not work. What this means for you is more time, a bit more money, and that sort of thing. So how do you have that conversation with patients up front? And how many times have you had to then sort of add composite or posteriorly or other restorations posteriorly to actually do more like a full mouth rehab?
I have to say, honestly, genuinely, I don't think that's ever happened, and I'm not kidding you.
It's because your case selection is really good, I'd say.
Probably is. I mean, there must have been your case where maybe I built a tooth up to get it into contact or something, but I think part of it is, the case selection is really important, and I think it's probably important. I'll run over a couple of things or cases not to do. That's important because this is where I see, and I have seen some people who are very well known in the industry, and they talk about Dahl, it doesn't work, and actually even show some case presentations or write blogs and stuff. And I'm looking at the cases and going, those are the wrong cases. Now, the problem is, who am I to say they're the wrong cases? I think the problem is there is a lot of Dahl theory out there. There's a lot of evidence and whatever it may be. But there's nothing really that talks a lot about case selection. There's nothing particularly about protocols. And no, I don't think anyone's ever done the studies on it. So what I would say is, fundamentally, number one, obviously, we've already talked about patients with warm posteriors. It's not a patient with warm posteriors. I'd also say any patient with perio issues is just a no-no. And certainly any patient with that's got, significant bone loss or anything like that is out of the question. Now,
But Tif, you find that your bruxist patients or your extremely parafunctional patients, they sort of select themselves because those who have periosusceptibility, they would have experienced it in a big way. I think there's no evidence to support perio, occlusion, parafunction stuff, but the kind that got like massive exostoses and stuff, that might be, maybe you'll come on to this, are those cases to avoid, Darlin, because maybe their teeth won't erupt as much?
Not necessarily. I mean, what I would say is one of the most important things also is to avoid a heavily misaligned posterior arch or arch forms that are heavily tilted. This is a really important one because I found...
Do you mean like a cant, like a maxillary cant?
Potentially, or posterior arches where they're just heavily misaligned, where you've got a lot of crossover on the molars. You've got like an instanding premolar.
Okay.
And I've seen that. I've actually seen quite a few cases have been posted online or one or two articles written. People have said, it's not sure if it's going to work. And I said, it's not going to work. And the way I view it is, if someone's got an instanding premolar, and they needed Dahl because why not just have a couple of months of ortho? It's not rocket science to move that too. That's the point. If you've got a little bit of Dahl is effectively like doing some ortho. It's like doing some ortho, but it's like a flat anterior bite plane. And I think anyone that's got, misaligned arches, because the way you've got to think about it is you're expecting this segment to sort of move. Now, the studies say it's eruption. I think there's a degree of compensation and potentially a touch of eruption. But the way I view it is that if you've got...
And maybe some joint repositioning, maybe?
Yeah, definitely. I mean, the joint repositioning's been shown and actually it's of benefit anyway. But no, you're absolutely right. But if you think about how the teeth actually move, I mean, I've looked at teeth slowly over the months that they move. And actually, they kind of, if you think about two teeth touching each other, two molars touching it, I've seen almost tiny mesiodistal rotations. Do you see what I mean? Almost tilt a little bit. So it's much more predictable if a patient's got a well-aligned arch. That's quite simply it. So, and if the patient's got a really bad arch, so there's like huge instanding premolars, canine tipped out to the side, then that's not a Dahl case to me. And that's really, really important. And I don't think enough people say that. And I've seen, a few occlusion gurus do cases like that and then complain it's unpredictable. And the reality is it doesn't work in those cases. Another classic one is the example of a stepped occlusion, where you've got someone who's already had, they've got, they've basically got a hugely already overcompensated 3-3 region. And I've seen people...
Like a massive curve of space.
Yeah. Again, that's 10 years too late. That case needs ortho to basically intrude those teeth and level the arch, and you may then do some bonding or whatever afterwards. Obviously, anterior open bite cases as well. There's no point as well.
Yeah, of course.
It's those sorts of cases that I won't do Dahl on. And what I would say is that it's really, really important to think about Dahl. And this is kind of what I hope this podcast will help people do. Is to start to think of it as interceptive treatment. And if you see in my presentation, but the cases that I show that I use Dahl on, they're not crazy cases. These are patients who are starting to get tooth wear, loss of anterior guidance. Yes, some of them are combined with ortho, so there's a bit of crowding and stuff as well. But what I did is I treated them, we hold their teeth in a better, more functional position and critically a retained position, better anterior guidance. And 5, 10, 15 years later, you look at the teeth and you think, well, if we hadn't done that, where would those teeth be now? You see what I mean? That's really the key. The key is to try and use it interceptively. Basically, it should not be a treatment that when you see a traditional, heavy tooth wear case, oh my God, look at the wear on that patient. I'm not thinking Dahl. You see what I mean? Other people think,
I agree.
People think, Dahl's the alternative to occlusion. No, it's not. It's not. And actually, it's an adjunct. And I know Ian Buckle really well, and he's a really good friend of mine. And we're actually doing.
I'm doing the Dawson modules with him. I'm on module 3 in January. So yes, Ian, top man.
Exactly. And Ian, I meet and I talk to Ian all the time, and he's running a course with IAS and doing some pieces with us. But he came in and sat and watched my lecture, and he's basically said to me, this is the bit that kind of is missing from a lot of traditional approaches, because what we end up doing is fixing a problem which could have been prevented all along. Now, what you're doing and what you're learning within, you need to learn, because there's always going to be patients that never go to the dentist. There's always going to be patients who never go, their teeth wear, and they get to that point where what you are learning from Ian, you will be able to offer the patient a very viable treatment. But the point being is there's a lot of patients who go through their whole life seeing a dentist every 6 months. Their teeth are gradually wearing. Anterior guidance is reducing. Their bite potentially could be deepening. They may be getting more loss of canine width. And the dentist says nothing.
And dentists don't diagnose, and I can say this because I didn't used to, so my story is, and I've said it on a podcast episode before, is that when I was a first year, after DF1, associate part-time, I'd read the prosthodontist notes and the patient's not in front of me because the previous practice owner was a prosthodontist. And he'd said there's a line, wear facets, upper right 5, upper left 4, lower left 6. And I'd look at the teeth and wait, I don't see anything.
Yeah. I know, and exactly.
Oh my goodness! And when you start seeing them, you start seeing them. And so now on my exact coding, there's a code we make, a TW. It's an orange, so tooth wear for me. And my system, and maybe you have a better system, Tif. I'd love to know it. Other than photos, your system of photos is very comprehensive. Each individual tooth, that's as comprehensive as it gets. But my charting system is I put one tooth wear if there's been any degree of tooth wear from attrition, if you like, or erosion. But if there's dentine exposed, I put tooth wear times tooth. There'll be 2 TWs on that tooth code. So, but I'm the only one I know, especially in my circle of friends, dentists, other associates, principals I work with. No one does that.
Well, I think, the problem is, and we're actually getting into political territory, and I'm not afraid to do that, but I think the problem is that our system has kind of encouraged us not to. The system, the way it is now, particularly with UDAs, almost gets to the point where if a dentist identifies this problem, you have to tell the patient, and then what's the solution going to be? It's that I don't understand how UDAs work. What I do understand is, from my understanding, for dentists, identifies a problem, offers a solution to a patient, they're probably going to have to spend a lot of time on it, and they're not going to get the fee to justify the time. Is that correct, or am I incorrect? It's correct, isn't it? So actually our system is sort of discouraging people to actually even to talk about it. And you think about it, how, that is just astounding. I find it, particularly being in private dentistry for a while, and I think about, you think about what the NHS offers. In my head, if the NHS was fee per item and actually was core service, I'd go back to it in a heartbeat. I would do. I actually believe in it. But I think the biggest problem we've got is we've got a system which has been created by people. And, I'm not going to point the finger at any individuals here, but it's been created by people who actually don't understand dentistry. They don't understand long-term dentistry. It's all about fix and it's all about politics. And I think the problem is, when it was fee, the reality is when it was fee per item, it was a lot easier to do Dahl. It was a long-term career. I came from a very kind of privileged era where actually we had fee per item, we had NHS patients, we could talk about the difference between private and dentistry, and we could offer them different things. UDAs meant that became very difficult, and actually it pushed dentists into a corner. And the way I think about it is those people that thought that UDAs was a good idea, that I actually think they need to be made accountable for, because the damage that they've done to the profession over the years is absolutely spectacular, because it's made it very, very, very difficult for dentists to actually talk honestly with their patients. And actually it's created this whole, I'm either private or I'm NHS. And this is kind of why I'm saying it's harder for young dentists to be able to convert their patients. It can be done, but the problem is that, you've got this scenario that makes it hard. And kind of, I'm going off subject slightly, but the reality.
No, not at all. This is important. This is the real world issues that we face.
This is why I think that, Dahl is something that it's difficult because it sort of can't be offered. Now, what I do say to dentists is actually a lot of cases that have Dahl sometimes need ortho. And the best thing about ortho is if you're an adult, you're not having it. So actually it makes the conversation quite a bit easier. So you can kind of say this is a whole ortho restorative treatment plan, and you could potentially take your conversation that direction. But fundamentally, so Dahl should be an interventive treatment based on people who you've been speaking to, and you're identifying sort of slow changes. And as I said, you're trying to prevent. The way I look at it, Dahl is for me to try and prevent a full mouth rehab. And actually, I actually take a view that if I see a full mouth rehab, it's not something to celebrate. It's actually an abhorrent reflection of the fact that our profession can't cope with those patients and fails to prevent those patients from getting there. And our goal should be to always stop it. And in my practice, I can genuinely say any patient that's come to see me and stayed with me has never, ever gone on to their need a full mouth rehab. So I've treated some. Of course, you treat some because they walk through the door. But no patient I've got actually a patient yesterday, it's a lovely lady, she's 86, and she's on her 4th Dahl recycle nearly 26 years later. Okay, and when I say
wow,
I mean, obviously I don't take the material off and put the same material back on. What I mean is we strip it off. Someone did ask that question when I said the term recycle. But I'm getting all a bit Greta Thunberg here with recycle and stuff. But basically, yeah, it's when the Dahl cases wear down and start to look bad and start to fail, and they're not guiding anymore, you literally strip it off, start again. And the problem with that, there's no evidence, there's nothing to say how many times you can redo it, what's actually happening. But I'm on my 4th. Who knows? Hopefully we'll get to my 5th with her, but we'll see.
That's interesting, actually. So, when we're doing repeat, will the sort of mechanics of Dahl continue to work? And obviously they do, because you've been doing it. So that obviously works. And I think it's a great philosophy. It's a great way you run your practicing life. And honestly, you're a massive inspiration to young dentists, Tif. I just want to leave you with 3 little reflections, and I want to hear your views on this, and then we'll, for interest of time, we'll call it a day. Yeah. So first thing you mentioned about the in-standing premolar sort of scenario. So in that scenario, I'm thinking, okay, this patient would benefit or, quote unquote, benefit from orthodontics, or it would be an alternative plan. So in that orthodontic plan, would you then be intruding the anteriors to then create the space to then rebin the guide? Is that sort of where you were getting to as well, instead of doing a Dahl?
Yep, definitely. Because actually, one of the best ways of fixing the lack of anterior space is with ortho. And if ortho is appropriate, and if there is actually anterior crowding or anterior tooth movements that need doing, then that needs to be offered to the patient. The patient may not choose it, and I probably say some patients don't. And if they've only got an in-standing premolar, and it can be fixed very simply. Sometimes they say, just fix that, we'll do the rest of it with the build-up. You see what I mean? So, but the option has to be on the table. And as with ortho, every option has to be comprehensive, has to be on every,
Absolutely.
And the patient can make the decision, really. So, but yeah, it may well be, and it's happened. It's happened in many cases that I've come across in the past where we've done that, or actually in many cases the orthodontists I referred to have done that.
Brilliant. And the next thing, last of the 2 I want to talk about is now with the advent of an accessibility of digital dentistry, and you mentioned scanners, are you doing this thing whereby your Dahl cases, you're seeing them every couple of months and then scanning them and doing like a little time lapse? Because if that study needs to be done, we would learn so much from that.
No, I am, and actually, it's quite interesting because I've got a new scanner. I had a scanner for about 18 months on loan, which was wonderful having it on loan. And I did quite a lot of scans on those cases. And what I'm trying to do now is actually marry up those original scans with those same patients. But anyway, we had a new scanner for about I don't know 6 weeks or so now. I'm scanning so many patients now for the basis of patient monitoring. But yes, also I've been doing a couple of Dahl cases where I've scanned those, and now I'm actually the plan is to then see the patients in a month and then rescan them and see the patient in 3 months.
We could learn so much as a profession from that, and also about the mechanics of it, which is a little bit disputed, I guess. So that's amazing that you're doing that, and I can't think of anyone better who's doing that.
I've got to give a call out to one of my friends, Andy Wallace, who's even further ahead on the curve than me on that one, because I know he's got a couple of cases at the moment. He's sort of mid scanning, so it'd be interesting. I'm actually waiting to see his results.
Andy's a top guy and part of the Tubule sort of crew, and I went to his Inman course actually. So yes, shout out to Andy. Thank you so much for the work you do. The last reflection is my theory on why some dentists are against Dahl is it means that their big tickets will not come through. So basically, you have to charge the patient way less. You're being way more minimal, and you don't get to do the posteriors, and that could be a reason why maybe Dahl is not favoured.
I think it is one reason. It's definitely not the only reason. I think we've covered some of the reasons in that perhaps a lot of the, if you use the term gurus, those gurus are seeing those patients way too late, and those gurus perhaps also don't have regular patients. Perhaps, they're acting like pseudo specialists. It's like
they're in a niche area where they wouldn't see the sort of interceptive opportunities.
Exactly, and they're seeing patients who are already too far gone, and that's completely understandable. But there is definitely an element. I don't think so much in this country. I really do believe in this country and most of Europe that I think that really are health professionals first and business people second. And I appreciate there are other areas of the world that may be a little bit different. But I do think that ultimately, we do hopefully think what's right for patients is best. But yeah, there is definitely. I have sort of given lectures on Dahl in various countries around the world, and had a couple of people sort of say to me, well, this is all well and good, but what about the milling machine I've just bought, and what about this, and what about that? And I'm thinking,
what about the bottom line?
Yeah, and that's fair enough. I kind of, it's be very easy for me to get angry about that. I think, you should be thinking about the patient, but ultimately I can understand why they're thinking that. But I think that's a very short, kind of narrow-minded and perhaps short-term view, because as I said, if we were all less focused on this big ticket, new patient walk through the door, I'm going to charge them 5 or 10 grand type of thing, and you thought about a patient, about keeping that patient for life, you thought about all the people they were going to refer into you that you don't have to kind of fight with mentally and try and worry about getting sued by them and all that sort of stuff. You think about, that sort of enjoyment you get out of seeing your work 5-10 years later. And, I think perhaps that's the problem. I don't think enough dentists do, because I don't think enough dentists think that's a thing to do. Then actually, I think there's this sort of long-term view, and I call it, a lot of my lectures now, I call it the lifetime patient. That's a term that I use. And I think that the more we think about that, and the more that word and that process gets put out there, the more hopefully people will realise that dentistry is not just about, it's not just about big ticket. It's not just about Instagram. It's not about, here's my before and afters. It's about here's before and after 5 years later. Here it is 10 years later failing. And this is why it's failing. And is it failing? the patient's still happy and the patient still loves me, and that's just a different view. So I think that there's a lot. I've kind of come away from it. Helped being a cosmetic dentist. It helped with me being that sort of person that thought I was like this hot shot walking around in the white suit with my name written on it and all that kind of stuff. And I thought, oh yeah, I'm a superstar. But over time, I realised actually I learned a huge amount from that. And I don't mean to belittle anyone that does that.
Of course.
I learned a massive amount from smile design, impression taken. But actually, what I didn't learn was ethics. And I'm not saying that they need to learn that, but I think being a general practitioner and seeing the work that you did that you probably realise you shouldn't have done come back to actually haunt you, and you having to fix it, and you having to, a case that I sold with smile design technology. 20 years ago, we had a version of digital smile design. And I remember selling cases like that. And I kind of looked at them 5 to 10 years later thinking, why did I do that? And actually, that's, I think, it's probably the one, for my generation of dentists, it's probably the one, it's a terrible thing to go through, but actually it's one advantage, a way of learning what not to do. I think that's really, really valuable as well.
And you're so honest to talk about these matters, and honestly just highlights your ethos and everything you're about. And with this episode, it's so many gems in there. And even though it's been, I think, 2-3 years since I did your course, it was good to see I retained a lot of information. But again, there are a few gems that you gave me that I can implement Monday morning. And
it's changed quite a bit since then, actually. So come back again. It's changed quite a bit since then. I've kind of restructured it.
Brilliant. Okay, well, I'll have to, and I'm looking forward to sharing that case that I told you about with the faucet appliance. I really want your input on it. I mean, more than anyone. So I'll put that on as well. So
where does that appliance come from? Who created that?
So Gary Unterbrink, Switzerland.
Yeah, Gary Unterbrink. That's the name. Yeah. That was the name. I remember missing a lecture of his and thinking, damn, I wish I watched it, because then everyone was talking about it after. He might have been at BACD or somewhere and I missed him. Anyway, thank you for that. Yeah.
No, I'll tag you in that when I can. But Tif, thank you so much for coming on and inspiring everyone. As always, keep doing your thing. What you're doing for our profession is amazing. And again, I'm so glad that you're getting this prize, which obviously means so much to you. And I'm so glad that you're a dentist from the UK and we have someone to look up to. So thank you so much, Tif.
Thank you very much, Shaz. Take care. Speak later on.
Thank you. Cheers.
So there we have it, folks. As a dental geek, I absolutely loved having Tif Qureshi on the show. I hope you gained a lot from his 2 episodes. That case that I mentioned to Tif, the one that I would tag him in it, of me using the FOSS appliance and my Dahl protocol, I did actually post that on Facebook with about 60 photos, step by step. I'm a huge fan of doing step-by-step photos because I've done it before, obviously, but I don't like the whole thing. Here's a before and after. Look how awesome I am. I like to teach and share, and I'm open to getting criticized and scrutinized. I feel like if someone can criticize me and scrutinize me, I will become a better dentist from it. So I've actually posted my entire protocol of a Dahl case on my Facebook. So the way you can easily access it, instead of me giving you like a long sort of URL, is if you just go to www.jazz.dental/Dahl, that's DAHL, then it will redirect you to my Facebook page, to the album that has all the 60 photos. Let me know what you think, and you'll see the FOSS appliance in action, which has just been fantastic for my Dahl cases. And if you want to learn more about this type of splint, there is a hands-on course happening in February. If you want more information, please message me. It's me who's teaching on it, but it's mostly being marketed internally to the people who use this lab, but there might be a few places available, and if you're interested, it's in Thatcham near Reading, Newbury way. So please message me if you're interested in that, hit me up on Instagram. So thank you so much for listening all the way to the end, and I'm really looking forward to the next one. Thank you so much, everyone.